Hello, everyone. A very good evening to you all. It's so heartening to see the enthusiastic response of audience and then to know of their feedback after the webinar. We have been doing webinar every Saturday, and this is the sixth webinar. Thank you all for participating once again enthusiastically. Every week we bring to you achievers in life in their own chosen field of knowledge and expertise. Hopefully, we will utilize this unique opportunity we are going through now in listening and learning from others' wisdom. The human body is a masterpiece of engineering. Architect of all this is God Almighty, who always has the final say. All the doctors, surgeons are engineering masons of different capacities, if we may say. Some are plumbers, some are carpenters, and some are electricians and so on of the human body. In today's world, almost in all spheres of life, we need computers to give us that precision and quickness in doing things. Either be it in the world of commerce, or even in the field of cooking at home, we have computerized gadgets. How can the all-pervasive medical field not utilize it for the benefit of patients? Gone are the days where doctors would do guesswork. Actually, there were doctors who were very good at guessing, but the percentage of such doctors were quite less. Today, using computer techniques, patient's anatomy, pathology, in investigating various ailments threadbare to arrive at the diagnosis and the course of treatment is so very developed. What more, even in surgeries, computers play a humongous role to assist the doctors. Right from X-rays, ultrasound, CT scans, MRI, etc. are used in investigations. We have different types of scopes used through natural openings in human body. The next step is to send the scope through invasive procedures at a particular part of a body. Further to that is the invasive surgery by opening up the body using knives, etc. Computers indeed play a very vital role in every step of the procedure that we just mentioned. We have an expert today from medical fraternity who is an orthopedic surgeon. He has proudly taken after his illustrious father, Dr. Mani, who was also an orthopedic surgeon. Our today's guest of honor has highly qualified in computer-assisted or navigated surgery for total replacements and also in keyhole surgeries where open invasive surgeries are not called for. He has over 33 years of experience, having possibly done over 1,000 surgeries. One thing I feel spellbound about him is that he has studied and qualified in his subjects, not from one country, but from 6 other countries of the world. This is something amazing. Having done his MS in India, Armed Forces Medical College, AFMC Pune, he has passed out of exams in countries such as UK, Canada, Swiss, Japan, Germany, and Australia. We can very rarely come across such surgeons, and more particularly so, we are fortunate to have him today with us to share his experience. He travels to Africa every alternate month for a few weeks, which includes Nigeria, Sudan, and Tanzania, often to treat patients and perform surgeries there. In particular, my dear friends, I have an extra privilege in introducing our guest of honor today because he is also my dear loving brother. I'm so proud of you, Dr. Ramesh. He's Professor Dr. Mani Ramesh.
Thanks for the kind comments.
Yeah. Thanks. You're welcome, brother. You see, as I just told you, you have studied in all these countries, boss. First, tell me what all you studied in these countries. Such an incredible feat that you have and
Well,
such huge
it's
qualifications. I know
well.
you did your AFMC at Armed Forces Medical College. You did your MS Ortho, and then you went overseas.
I went overseas in '92, and I was in both UK and Ireland for almost 9 years. The lion's share of my education and training and higher studies. I must say I owe it a lot to both UK and the Ireland, where I did my MCH in orthopedics and then did a lot of research. Did my initial peer review journals with the JBJS and did my specialist registrar training. Started my locum consultancy in Ireland. So that was the formative years of my basic training, and I am what I am today is mainly because of my training in both UK and Ireland. And then, of course, in 2001, I got Euro citizenship, but somehow, for some silly reason, I said, no, I don't want it. I want to be an Indian, because we had the dual citizenship problems those days. Anyway, at 2001, I went to Canada, and then I did my basic fellowship training in arthroplasty in both hips and knees in the Toronto East General Hospital for almost 3 years. And that was my basic arthroplasty fellowship and fellowship training. And in between, during the time between Europe and North America, I went to the other part of Europe. That is, I went to Germany and did my training in pelvic established surgeries. I went to Switzerland for my basic AO courses, and then I also went to Australia to do my training in computer-assisted surgery for hips and knees. So this is what it is. Only later on, once I came back to India, in 2004, and then after that I made my trip to both Japan and South Korea to fine tune my arthroplasty and computer navigation training. And of course, I've now been in India for almost more than a decade, and almost 1.5 decades, you can say. And now settled down, and I'm now a professor in Muthukumran Medical College, and I do private practice in a couple of private hospitals like Prashant, Chennai, Meenakshi, Orthomed. So, and I have a small clinic at home. So I do still run around, and I do like to practice as long as God gives me good health for the next decade or so, and do a lot of good work. My specialty, or rather my my ambition, or rather my goal is to do. Since I'm trained in computer navigation surgery, I do a lot of computer navigation surgery whenever I can. And plastic surgeon, and as you rightly said, I go to Africa every alternate months to do surgeries in Sudan, Tanzania, Nigeria, to also do that. So it keeps me well occupied, and it also gives me the satisfaction of doing good work.
Nice. So you first picked up your computer navigated procedure in Australia, is it? The first place
yes,
where you
I got my basic training. To be honest, I did travel to Bombay. There was a chap called Arun Mullaji, and there was who first showed me the know-how of computer navigation.
Okay.
And then, of course, I went to Australia to learn. In Australia, they have the big lab, computer navigation lab, and also in Germany, in Munich, wherein I also went to look at the fine tunes, and from there I went to Stuttgart to meet my cousin too. If you get the basic training from the right people, then you get your basics right.
You had that focus in going country after country and learning the same thing, in a very specialized manner. That's very nice. Now, you spent about 14 years away from our country, and then when you came back, how did you find the medical facilities in India? How is it compared to the Western countries?
Oh, I must say India is very good, is in absolutely on par with the rest of the world, is almost amongst the top nations in the world as far as Medicare is concerned.
Uh-huh.
Most of our Indian doctors are the ones who do very well both in UK and the USA. I
Hmm.
must say that we are excellent, and that's why medical tourism is so much in India, and people flock to Chennai and Bombay, mainly because our doctors are very well trained and have the expertise. So India is way ahead of most of the country. Yeah.
Now, today you're going to talk to us about the awareness of joint replacements, your area of specialty. What do you mean by awareness? Does India lack awareness?
No, yeah, well, the thing is, if I put it in a very simple way, say for example, if I tell a patient today in Chennai, sir, you need a knee replacement, and if I tell the same thing to a patient in say UK or the USA, they will immediately say, when is the earliest you can do it for me? Why is
Hmm.
it that in India alone we find excuses? We say, I have to get my daughter married, or I have to go for this conference, or I would like to postpone it to the following year. It is not the financial aspect, because now with all the insurances and everything, we have the money to do the joint replacements. And especially now after the Modi government has reduced the cost of the knee replacement to say the prosthesis, that is the implant that goes into almost only 55,000, which used to cost about 90,000 before
Oh,
brought this rule. But we are thankful to him for that. But the thing is, the people are not aware. The people are not aware of the benefits of joint replacement. That is what I'm trying to say. People are so scared. They almost like as though, will I live after the surgery? One thing we must understand: that joint replacement is not a life-saving surgery. It is a limb-saving surgery.
okay,
So, which
okay.
means the patient will do very well after a joint replacement, whether it be hip or whether it be knee. The entire lifestyle changes. Say some patients recover very fast, say in about 6 weeks. Some patients would take say about 3 months. But on an average, by about 3 months' time, their entire lifestyle has changed. They can throw away their stick, they can walk, especially people who need bilateral knee replacements done or bilateral hip replacements done due to certain ailments like rheumatoid or advanced osteoarthritis. Their entire lifestyle changes, and who have not been able to even stand and cook in the kitchen, who have not
Uh-huh.
been take a walk, who have not been able to do their normal activities. They are so thankful that their entire lifestyle has changed. So it's very important to realize this and to be able to get these replacements done. These counseling sessions for patients have become so important that nowadays doctors even have nurses specified for counseling with videos to show them how the patients were benefited after surgery, to show them the implants, to show them small videos about the surgery, and to explain to them what it involves in terms of rehabilitation and how easy it is and how you get back home, say within a week, and the entire process, right from how you are before surgery to what happens during surgery and how you recover. All that is very important. And the counseling is so important that the patients, once they understand what a joint replacement involves, then the patients will be very willing to come forward and get the surgery done. I know many of the patients immediately jump into Google and read all about it, but unfortunately they pick up all the wrong informations about the complications, about this, about that, all the bad things. Of course, every procedure, everything has its own percentage. Say, for example, you do a hip or a knee replacement, there will be 1 to 2% chance of complications coming in, but that's not what you look at. You can, if today you fly, you because the PIA plane crashed, uh, everything comes with its risks. How do you make sure that your risks are almost down to zero? You choose a good doctor, a doctor with whom you're confident, who is well trained, who is a good surgeon. You go to a good hospital, they use a good equipments, and they give you good rehabilitation and good physiotherapy and good care till you cross the 3 months after surgery. If that surgeon is able to deliver that goods, then you can know that you are in the right hands. I try to very much follow the UK system, wherein I don't just say in a week or 10 days, your surgery is over, you can go home, tata, bye bye. I don't say that to the patient. I make sure that I keep in touch with the patient. I make sure I send the nurse to the patient's home. I make sure there is a home physio, there is a rehabilitation protocol. I see the patients at 1 month, at 6 weeks, 2 months, and at 3 months. Make sure, take an X-ray at the end of 3 months, make sure they walk. Give them so much confidence as they would do in the UK, prolonged rehabilitation till the 3-month period. And that's when the patient is satisfied and is able to get the confidence that the patient is able to deliver the goods. This is what I mean by awareness.
So on one hand, we have a very big expertise, and on the other hand, awareness still has to be improved.
Yes.
That's what I'm able to understand. Maybe the government participation or the big hospitals participation in this connection will...
Yes. And of course, so many times you see patients doing a lot of medical shopping. They go from one doctor to another doctor to another doctor till they hear what they want to hear from the doctor. Say somebody comes and says, you don't need the surgery now. Oh, that doctor told me I don't need the surgery. So sometimes patients, they defeat their entire purpose. They defeat themselves, and they don't understand what is good for them when it comes from the doctor's mouth that you need to get this done. Because it's such a vast topic. I can keep on talking and talking, but the point is, you have to draw a line somewhere when you know that you need the surgery, that your knee or hip is very much advanced. And there is something called comorbid conditions, which means you have sugar, you have blood pressure, you have asthma, you have some other medical ailments. So you could have a good 80, that means who doesn't have any comorbid conditions, and you can safely do the surgery. You can have a bad 60. That means a 60-year-old with so many medical problems. So one has to draw the line, one has to develop faith, one has to develop confidence in the surgeon, and one has to go by it. You don't gain anything by going and doing medical shopping. Maybe you can get one more opinion, maybe a second opinion, but don't go for third opinion, fourth opinion, fifth opinion. It just confuses you.
The mindset has to evolve over a period of time in the amongst the Indian population. I suppose it will evolve.
Yeah.
Well, Ramesh, okay, now before we talk about surgery, I want to make sure that my knee joint is strong. So how does one take care of the knee joint to make sure that, we don't come to you for surgery tomorrow?
Well, you can't. I'll be wrong if I say that you will not come, but because osteoarthritis or degeneration of the joint happens to everybody beyond the age of 60-65 years. In some people it will be marginal, some people it will be much more advanced, some people the arthritis will start at a very young age, some people it can start as early as 20s, 30s due to other comorbid conditions like other inflammatory arthritis or avascular necrosis, which means lack of blood supply, without going too much into the medical depths. So what I'm trying to say is that there are many conditions wherein you will not get your illnesses for the knee joint. But on a general term, yes, exercising, taking long walks, building up your muscles, and cycling, and all this will definitely help. So basically, mobility is life. So basically, as they say, the footballer's thigh, which has got powerful quadriceps, that is a strong knee. So I'm not telling you to build up a very bulky or very powerful thighs in order to prevent your knee. But what I'm trying to say is that you have to keep walking, exercising, and keep yourself mobile. Hydrotherapy, swimming, things like that. Yoga, all that will help you to really build up your knees and hips. Yeah.
Food intake also, people say by having turmeric in your food preparations will help you.
I will not go into commenting on the dietary requirements. All I will say is don't be obese. Because obesity is directly proportional to developing arthritis in the hips and knees, because the knee joints takes time to body weight. So I will just say maintain your BMI, your body mass index, make sure that you don't put on weight, have a healthy diet, exercise, healthy living, yoga. I think these are the basic things which one
There
has
are
to.
hundreds of types of arthritis, isn't it? There are hundreds of types of
Well,
arthritis.
there are many because the most common is the degenerative arthritis called as osteoarthritis. There are many inflammatory arthritis like rheumatoid arthritis, gout, pseudo gout. You can keep on naming ankylosing spondylitis and so many other things.
What are the early signs, Ramesh? What are the early signs of a person identifying that he is developing arthritis?
Well, it all depends on what type of arthritis you're talking about. If you're talking about inflammatory arthritis, then you have to see whether it is symmetrical, whether you're getting swelling in the joints, whether it is occurring in the big joints, whether it's occurring in the small joints, whether you're developing swelling, whether you're developing difficulty in using your activity. I think we're going too much into the depths of rheumatology. We won't go link, but basically, one needs to be aware and one needs to know that if he is having difficulty in his activities of daily living, to take help and needs to take advice.
If it is degenerative, then I think there is no scope for reversing the arthritis totally, isn't it?
Well, I wouldn't say no scope. We can definitely delay the progress of arthritis in the sense, say for example, you have a late middle age to say 55, 60-year-old gentleman who comes with pain in both the knees, and I examine him. I find that he's got a lot of crackles. He's got very degenerative knees. He hasn't got much comorbid conditions. So in these kind of, I wouldn't jump straight away into doing a knee replacement. What are the conservative ways of treatment of a patient, depending upon when and at what stage the patient walks into the surgeon's office? So what are the various ways, starting with simple analgesics that we can give? Of course, it has to be covered with antacids so that he doesn't develop an acidity. We can give him a good physiotherapy regime wherein he can build up his quadriceps, his hamstrings, and the various hip muscles. We can give him a lot of braces. Basically, it's hinged braces, hinged braces, a straight knee brace or a short knee hinged brace or a long knee hinged brace, depending upon what the patient requires. But the important thing is you should not give braces for both the knees. If you give braces for both the knees, then the patient cannot walk. For the most affected knee, and for the other knee, you give a very small, like a kneecap or something like that, so that the patient has the support of the knee. Then the next modality of treatment is hydrotherapy, like going for swimming or walking in the swimming pool very fast with water resistance. All that helps to build up the muscles. Then you have what is called as keyhole surgery or arthroscopic surgery, wherein you debride the knee joint. And depending upon how young the patient is below 50, then we can do what is called as cartilage repair, mosaic plasty, repairing the ligaments. All that can be done. But once patient crosses 50, 55 years old, then it's mainly a question of debridement or a washout. We call it haircut of the knee. Bone out particles, remove all the loose bodies, give it a thorough wash. And then there is something called as visco supplements. Before, people used to inject a lot of hydrocortisone into the knee and local anesthetic like xylocaine. But now we're moving on to Synvisc. Synvisc is a visco supplement. Visco supplement is almost like injecting a fluid into the knee, which almost simulates the solution which is there in a joint. So it helps to nutrition the knee, helps to lubricate the knee, and helps to give pain relief. And that it can give you relief if you're lucky for up to about a year or so. So you can repeat the injections every year for about 3 injections or so. It has to be done in a very sterile environment in the small minor OT, not in the consultant's room. So there are a lot of procedures one can do in order to postpone surgery. But again, having said that, it depends on what stage the patient comes to you and how advanced the arthritis is, how much of comorbid conditions the patient has, and how much the patient is enthusiastic to get along and get the surgery done. So I never force the surgery on the patient, because it will come back to you. But I take my time and I explain to the patient all the pros and cons and put it to the patient and explain to them that this is your benefits and are you willing, are you ready, we'll go ahead, and then we go ahead. So that's how
a patient of say about 60 years old, if he has got conditions to go through the total knee replacement, and if he tries to postpone it, comes back to you after about 5 years, 10 years, by that time he would have developed other physical complications as well. So it's to his disadvantage. Earlier the better, because it's not going to get reversed.
Yes, absolutely. Because that is something which is a very sad situation. I've had my own relatives whom I've suggested to have a bilateral knee replacement when the patient was very fit and had very minimal comorbid conditions. The same patient came back to me after 5 years later and said, I'm not able to mobilize, please do it. But by the time she had other comorbid conditions which prevented me from, which could not be controlled, like uncontrolled diabetes and various malignancy having set in. So you can't do surgeries in such kind of conditions. So it's very sad, because you have lost 5 years of your life wherein you could have had a good quality life. Now, I just take a minute, Shankar, just to say about bilateral knee replacements at this stage. Now, patients sometimes come to us with both the knees being involved. Sometimes both the knees are equally involved. Sometimes one knee is more involved than the other. But I tell them that unless one knee is almost normal, that means that knee is pain-free, that means there is no pain at all, then only you do one knee. But when you have both the knees involved and both the knees are equally painful, or maybe one is slightly more than the rest, other but still painful, then I suggest a bilateral knee replacement. I think I'll make it very simple that the American and the British journals suggest that one should do the bilateral knee replacements before the age of 75. So which means patient will be fit enough to tolerate and get the surgeries done. There are 4 types of bilateral knees, which means you can do the 2 knees in one anesthetic, in one sitting, by 2 sets of surgeons called simultaneous, or by the same surgeon, one knee after the other called sequential. You can do it in the same admission, one knee this Monday and the other knee the next Monday, called a staggered, or do the other knee after 3 months or more, which is called staged. So sequential, simultaneous, staggered, and staged. So the 4 S's. So these are the different ways by which one can do a bilateral knee, or for that matter, even bilateral hips. I have done even bilateral hips for patients. But the point I'm trying to stress is that this decision of whether to do it sequential, simultaneous, staggered, or staged should be left to the surgeon, because the surgeon will be able to advise the patient what is the best for him or her, depending upon their comorbid conditions, and how best we can get the best results. Because just imagine if one knee is, if both the knees are involved, and you just straighten one knee and try and go ahead and do the surgery, the other knee will prevent you from walking and rehabilitating very well. There's a lot to learn from this. And of course, some of my colleagues, one of my colleagues in Hyderabad is a very heroic surgeon. He replaced both the hips and both the knees in one sitting, and he was all over the newspaper and television. Of course, then he said it was a mistake. I shouldn't have done that, because it puts a lot of strain on the patient, and a lot of strain for the anesthetist too, because they have to make sure that the patient is in good condition at the end of the surgery. So trying to do both hips and both knees in one sitting is a no-no. But you can do 2 hips or 2 knees at the same sitting and produce very good results. Money should not be, actually, good you brought up this point. You should not be counting your money when you come for major surgeries like joint replacements, because I know some surgeons tell their patients, yes, you will save 50,000, 75,000, even up to 1 lakh if you get both your knees done at the same time. But that's the wrong way to convince patients, because it's not money that is important. What is important is that the patient benefits and does well, and patient gets good clinical results. That is what is important, not the amount of money that one saves.
No, it saves on giving anesthesia for twice, isn't it? In short intervals. If
Sorry?
The patient is saved from getting anesthetized 2 times.
It's not a big deal.
And if it's particularly...
It's not a big deal because nowadays you give a spinal epidural anesthesia. You can give a spinal and epidural. Epidural is like they put for women when they deliver babies. And you do the one knee, and the second knee, the epidural still continues. And sometimes you can top it up for the second knee. Maybe give a little holder mask because the knee replacement hardly takes 1 hour to get it done. So it's not a big deal.
What is the longevity of the surgeries?
It's a good question. the prosthesis from the time knee replacements got popular in India, say in the 80s, thanks to our ex-Prime Minister Vajpayee. It used to be called the Vajpayee surgery because he got his knees done.
Bilateral, isn't it?
Yes. So that was about that time. The longevity of a knee was about 15 years. Today, the longevity of a knee replacement is about 30 years. So, which is excellent because even if a patient comes at 60 years old and gets a knee, he will get it till about 90, and I'm sure within 30 years is what we say on an average. So it could be slightly more, slightly less. So it's a one-term, lifelong operation as long as it's done well and it's done by the good surgeon in a good hospital, where they have the best of facilities with good post-op care.
Total knee replacement. It's not that as though you're changing any parts there. You're only resurfacing the.
That's right. It's a misnomer. It's not a replacement. It's a total knee resurfacing because you resurface the worn out areas of the lower end of the thigh bone, which is the femur, and the upper end of the tibia, which is the leg bone. You take off all the worn out portions using jigs. And then you flatten it out, and then you use cobalt chrome alloys, which is what the metal, which is what the prosthesis is made of, and you cement it in place as we put cement for the.
You do your carpentry work there.
Yes, exactly. It's a carpentry. We are glorified carpenters. Yes. Yeah.
So that's what you do. I mean, people have an idea that the entire joint, you find a new joint replaced.
It's not the entire joint. It's just the surface. Yes. So the entire, now that you, sorry, I'll just take a minute. Now that you brought that point up, the entire joint that you say, which can be taken off and replaced, is when you have tumor surgeries. Say, for example, a patient has a cancer, osteogenic sarcoma, as we say in medical terms, of the lower end of the thigh bone or the upper end of the tibia, wherein the entire bone, along with all its soft tissues, have to be removed. In that case, in that time, we have to remove the entire joint. And then we put what is called as custom mega prosthesis. So, which means the patient's knee is done, a CT scan is done, we find out what is the size of the prosthesis that needs to be fitted, and we then get it, and with the help of custom mega prosthesis, we do it. I have done a few of these. The important thing about this is that do not try to do the surgery by yourself. In the sense, I have a vascular surgeon as a standby, and I have a plastic surgeon as a standby. In one of my patients, not that I'm trying to scare the audience, but I'm just trying to explain because it's a multifactorial system wherein you get all the specialists to be there. In one of the cases, the blood vessel got clogged. So the pulses were not felt after the surgery. So I had to remove the prosthesis, and then the vascular surgeon came in. He found that the vessel had clogged. He immediately used a conduit. A conduit is an artificial arterial graft which was stitched, and then the pulsation came back. So that is important. You can't be ringing up for the vascular surgeon from the theater. And the other thing is the plastic surgeon, because sometimes when you put in this huge prosthesis into the knee joint, and with the lack of muscles and everything which you have excised, sometimes you're not able to close the wound. And in such cases, you will need the plastic surgeon's help for closure of the joints. These are all not in every patient. These are all for standbys. So what I'm trying to say is that the joint replacement has revolutionized so much that in the olden days, patient has got a cancer in the knee joint, take off his leg.
They either remove it below the knee or above the knee and be done with it.
Nowadays, with limb salvage, we are able to save the limb, and not just save the limb, and give a lot of expense to the patient, but also give a useful limb, as good as a good limb wherein the patient can walk by himself, even for gap non-unions, even for completely shattered bones. We're able to replace prosthesis with the thigh bone and the leg bone. So it's amazing as to what is available today in the market in terms of trying to save a patient's limb, and in order to give very good surgery and very good results for these patients.
Even in accident trauma cases, you can change the patella totally.
The patella joint, no, it depends. There are different types of surgeons who try to replace the patella. Some surgeons don't replace the patella. I don't replace the patella. I just shave the patella. It all depends on what one needs to do, what one is comfortable, what one needs to do, and how it is done during the routine knee replacement. That's a different topic that we need to discuss, not today.
Does everybody does this and all these procedures through a computer assisted surgery, or
No,
it can be done without that also?
No, computer navigation came with a big bang a couple of years ago. Then it went away because the problem with computer navigation is that the hospital has to invest in the computers, and not many hospitals could invest on the computers. But then, as time went by, the companies decided that they could lend the computers on loan basis, and so as to on a patient-to-patient, and they would charge the patient, say, 10,000 rupees extra, so that that goes for the loaning of the computer for the knee or hip replacement. It went to an extent that I found some Bombay surgeons carrying the computer in a suitcase and taking it with them they would buy the computer, take it in a suitcase, they would have an assistant who would set it up, and then they would do the surgery wherever they go. Computer navigation is excellent in terms of three ways: A, B, C. That is, A is for alignment, B is for balancing of soft tissues, and C is for component orientation. So to make you understand in a very simple way, is like, say, for example, your scooter has a puncture. My tire has a puncture. Please make the tire all right, but make sure the alignment and the balancing of the wheel is okay. So why do we want the alignment and balancing of the wheel to be okay, done by the computer rather than using your naked eye? Because your longevity of the tire is more, because wear and tear of the tire is less.
Okay.
So similarly, for a knee joint also, we want to do the same thing, and that's the advantage of using computer navigation.
And the robotic surgery is much different from the computer.
Yes, robotic surgery is different from computer navigation. It is still coming into vogue, wherein people are still trying to use robotic surgery. But I really, with computer navigation itself, not finding so much of like, we don't use computer navigation for all the cases. We select our cases wherein we want to use computer. Say, for example, the patient has a gross deformity. Deformity means very, very crooked joint, wherein we want to study how it is without exposing, and we want to use minimally invasive. So these are kind of indications wherein you use computer navigation. So trying to do joint replacement robotic surgery is a little far-fetched, but I don't know. I mean, it's still under research, and still a lot of research is going on before it can find its definite use.
There's lesser than a total knee replacement is also a unicompartmental knee replacement.
No, it's called as a unicondylar knee replacement. That means you replace only one side, either the inner side or the outer side. But the problem with the unicondylar knee replacement is that the cost is sometimes even more than a total knee. Total knee means you replace both the inner side and the outer side. So some patients say, if I can get a full joint for the same price as a half joint, why do I want a half joint? So, and if the unicondylar fails, then your next stage is a total knee replacement. So why do you want to have two surgeries when you can have the same thing done with one? The only advantage of unicondylar is the rehabilitation is faster, the physiotherapy is faster, the way the knee works is faster. But then if you have good dedicated surgeon, a good dedicated physiotherapist, and a good rehabilitation program, I don't see the real need for it.
How much, what percentage can be rehabilitated? A person who undergoes a bilateral knee replacement surgery, can he climb up the stairs on his own?
Yeah. See, for example, if you do just one knee, the basic rehab is the patient stands up after 48 hours once all the drains are removed. We make him walk initially with a walker, then he graduates to a stick, and then he starts climbing up and down stairs in about 6 weeks. In 2 months, he's going shopping, he's doing everything. So imagine if you've done a bilateral knee, add 1 month more. So probably in about 3 months or so, he should be fine. So that's how it is. The rehabilitation is faster, it is quicker, it is much better, and the patient satisfaction is pretty good.
And but you can't expect him to run, of course.
No, of course no, and we always tell patients who have had hip or knee replacements, and you can drive an automatic car, you can go for your walks, you can stand however long you want, you can sit however long you want, but you need a high chair, a high bed, a high commode, and do not sit cross-legged, do not kneel, do not squat. So basically we tell them not to use the floor. So we tell them you are now become a white man or a white lady as a joke, basically saying that Europeans don't use the floor. So you will have to change your lifestyle a little bit. It's only when we get patients from Dubai or the Gulf where they can't do the namaz, they can't sit on the floor and eat. Some of them get very emotional and they start crying and they say we can't do that. So we try to tell them sit in the steps or something, or sit against the wall with your legs straightened, things like that. These are small things, small sacrifices they have to make in their change in lifestyle, so that they can lead a pain-free, comfortable, independent life. So what I tell my patients is, to put it in one word, how does joint replacement help you? Put it in one word. You go from dependent to independent. All the people living in your house, you're dependent on your crutches, you're dependent on your walker, and once you get a joint replacement, you're totally independent. So that's the magic word that you will get if you do your joint replacement. If it's a primary hip or a primary knee, straightforward, it should take about 45 minutes to an hour. 1 hour is fine. But if it is a challenging hip or a challenging knee, it will take time. But as one of my bosses in AFMC used to say, it's not that duration of surgery is not what makes a good surgeon. It's the results that you produce, and so a fast surgeon need not necessarily be a good surgeon. You know what I mean?
Okay. Yeah. Like I am reminded of a similarity between a student and a surgeon. After their exams or after their surgery, if people come and ask how did it go on, say I did my best and leave the rest to God.
That's right. Yeah, it's always like that. I mean, you do the best you can, and you will be able to do well as long as you know what it is. And one of my UK bosses used to tell me, no matter how many surgeries you have done the same time, before you go in, think of all the possible ways in which you will go wrong at every stage, and see how you are going to come out of it at every stage. So, which means you have to do your homework for every stage. That things like, for example, right from making the incision, sometimes you make incision the wrong way. You don't cut the thing properly. You don't do this step properly. But for everything, you need to have a backup plan. So once you're mentally prepared, you have your backup plan, you know how to proceed, and you have gone through in your mind everything. If this fails, what do you do? If this fails, what do you do? Then you're a safe surgeon. That's what makes you a safe surgeon.
So for the sake of positivity, you think of all the negativities and then be prepared for it.
Yes, that's right. You've got to be positive and you've got to take it forward with that, and they will do well. They will do well.
What is the oldest patient that you operated upon, Ramesh, so far?
Well, in UK, I have done hemi-arthroplasty. That is a half a hip for 100-year-olds. But if you're talking about joint
100?
replacements, 100, yes, people
Did I hear it as
live
100?
along.
Oh,
They live along. But 90 plus is what I've done. The patients no comorbid conditions, and they want to get a good life, and they do it. The knee replacement, my oldest patient is 87. He is from Palghat. He was a bodybuilder, and he wanted good knees. They do well. You see many patients now, 70s, 80s, 90s, it's no longer a age, in terms of as long as you're healthy and you don't have much comorbid conditions, and we are able to control the comorbid conditions, you can give them a good life, lifestyle changes. Imagine you can't get up to go to the washroom, but now after the replacement, you're able to go to the washroom and come back, you're able to take an evening walk. That's a big boon for elderly.
And take care of your heart also as well.
Yes, exactly.
Yeah, that's
so it is a fantastic revolution. And of course, at this juncture, I'd also like to say that replacements have not only changed patients' lives, not only in terms of hips and knees, but you can do the replacement for the shoulders, the elbow, the wrist joint, especially for patients who have got rheumatoid arthritis, who are not able to move the shoulders or even the elbows, even the wrist joint. And even the ankle joint has come in, but still the gold standard is an arthrodesis, which means a fusion of the ankle joint. So replacement surgery, joint replacement, in short, arthroplasty, has come a really long way. The challenge that an arthroplasty surgeon faces is innumerable after the replacement. That means, to put it in just a few sentences, it's called revision arthroplasty. That means you do a replacement and then for some reason it fails. It fails due to so many reasons. I don't want to go into the medical things like osteolysis, loosening, infection, this, that, blah, blah, blah. There's a big list. But patients who come back, say for example, a patient at about 50, 55 had a replacement done and comes back, say at about 70, 75 or whatever, for some reason the prosthesis needs to be changed. That's when nowadays we have a huge armamentarium available for us, wherein we can replace or revise. This is called as revision arthroplasty, be it the hip, be it the knee. The biggest challenge India faces is we don't have bone banks. We don't have a good bone bank. There is a bone bank in Bombay called Tata Memorial Hospital, the Cancer Tata Memorial, wherein sometimes we go and in a very VIP case or a patient where we need bone, we go and get bone from there. Some private nursing homes in the south of India, we have some wherein they replace the femoral head which is broken. They save it in order to produce a bone bank, but then the chemicals are not very good. The point I'm trying to make, if you look at UK, you look at the States, or you look at many of the European countries like Germany, France, they have fantastic bone banks. Wherein, when you have a surgery that needs to be done, the preserved bone is taken and brought to the operating theatre, of course tested for AIDS, tested for hepatitis, all that, and then that is available. We do a revision arthroplasty. We do a revision arthroplasty by using augments, wedges, metallic metal replacements, which is basically which is more expensive to the patient. And sometimes we are able to take a chunk of bone if there is a femoral head or whatever is available. So the point I'm trying to say is, even when I go to Africa to do surgeries, I don't have access to bone banks. So if somebody can start a bone bank in Chennai or whatever and have a very good bone bank,
remove it from the cadaver bodies, is it?
Yes, as the patient, as you donate eyes, you donate lungs, you donate heart. Like that, you can donate bones. And if you have a good bone bank in Chennai, that would do a lot of good.
Oh, I see. Okay. And the patients who get into such type of complications, even at a young age, it happens, or it could be because of some genetic reasons they could develop arthritis at a younger age, or is it because?
Well, there's a lot of conditions, Shankar. The congenital, traumatic, as we say in medicine, for everything there are four causes: congenital, traumatic, inflammatory, neuro. So basically, they could have genetic defects. They could have dysplasia. That means the way the bones were formed. They could have problems. They could have avascular necrosis. They could have inflammatory diseases of the hips and knees. So there are many kind of conditions wherein they could get arthritis due to various inflammatory arthritis. So, and then due to trauma. So there are various reasons why one could get arthritis at a very young age. In fact, one of my colleagues' daughter, who was 18 or 17, she had avascular necrosis, which means lack of blood supply to the femoral head. And she had such painful hips, and she just couldn't carry on with her life. Luckily, his wife was in the movie field. And when she turned 21, she said, I am an adult. My mother has the money. If you're not going to replace my hips, I'm going to somebody else. He got both the hips of the daughter replaced. She is now dancing. She's a doctor. She's got kids. Her entire lifestyle has changed. Lifestyle has changed.
Okay.
Even when I went for my Calcutta camp about 4 or 5 years ago, I saw a mentally retarded girl who had both her hips, which was destroyed. She was only 21, and she was wrongly diagnosed in Calcutta as tuberculosis, and they were put on anti-tubercular treatment. Now, anti-tubercular treatment can damage the heart, can damage the liver, can damage the kidneys, can damage the eyes, can damage so many organs. If you cannot give anti-tubercular drugs unnecessarily.
Okay.
The moment I looked at the scans, I said, this is not TB, this is not it is, and stop all the drugs. After 3 to 6 months, bring her down to Chennai, I'll replace her hips.
Okay.
They brought her to Chennai, I replaced both her hips. I did what is called a hip resurfacing, wherein I gave a big head. She is running, she's doing everything, she's health is improved. It's so nice. I mean, she's mentally retarded, but to give her such a painless, good life it's so rewarding and so thankful.
And these rewards are more than the money you make in your profession.
That's right. Yeah, so it's very important that it's not just that once you turn 60 only you will have a damaged joint. You can have a damaged joint from birth. So it's not it's when you can start replacing it is probably 21. What I told you, once the bones stop growing and your skeletal maturity has achieved. I know your skeletal maturity was 16, 17, but 21 is when everything is perfect, and also the patient can take a decision rather than the parents forcing it on the children to do a replacement. So it's very challenging, joint replacement, very challenging. Even in Africa, sometime my last visit, I saw a patient who was a soldier in the Sudan army. His knee had so many gunshot wounds. Both his knees were completely stiff. It was like a rock. You just couldn't bend both the knees. But see the beauty, both the knees have been ankylosed. Ankylosed means the knees are fused. It got fused due to infection, various gunshot wounds. Both the knees are straight. He's somehow doing a trick movement with his hip muscles and is able to walk. He's got no pain in the knee. His wife had said, replace both my knees. I bluntly refused. It will fail because you've had old infection in both your knees. You're having a painless life, painless knees. You're able to serve in the army. You're able to lead a good life. You're able to earn your money. Go. I will not touch you. So there are many a time when you have to make a decision when not to operate. So patients will beg you for surgery, but you should be able to tell the patient, yes, you are a good candidate. Yes. So that's when you do a help to the patient by not operating. I would have done this patient a lot of injustice if I put my hand on it.
Okay.
It's a very challenging and very rewarding decision making, and not just cutting and operating. That's not just the surgery. You have to make important decisions, and sometimes you got to make decisions for the patient as well.
And what is an ideal comorbid condition you would suggest? Is it a good
comorbid condition? Yeah. Well, basically, say for example, a patient wants to. We decide to get surgery done. We ask the patient, what are the list of ailments you have? What are the list of medications you have? So then there are two ways. One, if the patient has insurance, then they have to get admitted and then go through, because then only the insurance will pay them. So basically, they have to see a general physician. They have to see a cardiologist, because all of them are above 50, 55. They have to see an anesthetist. So these three are a must. Sometimes they have to see an endocrinologist. And they have to assess the patient, and they have to see, even if they have uncontrolled diabetes, it could be controlled with insulin. If they have a high blood pressure, the cardiologist will see whether by doing an echo and things like that, whether the patient can withstand, what is the ejection fraction, basically making sure the patient can be fit for surgery. And then the endocrinologist to make sure that all the hormones are under control. So basically, we are trying to see if we can make the patient fit for surgery in about 1 to 2 to maximum 3 days. Fit in the sense, fit for anesthesia. That's what I'm trying to say. Okay. Surgery, excellent surgery. Surgery went very well, but the patient is not doing well. So that's not the point. So we have to see from the anesthetic point of view whether the patient will stand the anesthesia and will be able to come out of the surgery and then go to the ICU or the rehab ward, and then before going to the ward, whether the patient's rehabilitation will go smoothly. The idea of seeing whether their comorbid conditions can be under control. Excellent. Sometimes we find that the comorbid condition cannot be under control, and then we advise the patient that, I'm sorry, sir, or sorry, madam, you need to take these medications for a longer period of time. Come back to us after a month or 6 weeks once your general condition is improved, and then we take up. So it's very important. We make sure that the patient is fit. We make sure the patient will survive the surgery. The patient will do well, and will get all the. Sometimes the patient are on blood thinners, which is basically to prevent clotting. We have to stop that for a week. So this is the idea of making sure that the patient is fit and will be able to tolerate the surgery well.
Great, Ramesh. Great. It's wonderful. Well, you have really gone in depth and explained about the whole thing, and I'm sure the audience are quite eager to ask you some questions. Dear friends, those who want to raise questions, possibly you can post it in your chat box, and then we would invite you and ask Dr. Ramesh to respond to your questions. And before that, Ramesh, just to talk about, let's deviate a little bit for 1 or 2 minutes before we take questions. Being a busy doctor, how do you find time for your leisure? I know you are a cricket fan and you are a Dhoni fan. And do you find time to still go for sports?
I'm a big cricket enthusiast, CSK fan, okay. And I never miss a cricket match in the stadium. And I love going to the movies and music. So and of course I like the lighter side of life.
Yeah, you always come up with some lively jokes at times.
So it's always been there, and they used to call me Blade in college. Because I used to crack a lot of jokes. So I kind of enjoy it. I try to enjoy life to the maximum and be happy and keep going. I think it's very important because unless one have their own kind of ways to distract and see the lighter side of life, it's very difficult to.
No, there are a lot of jokes on doctors. It says in the middle of the operation table, the doctor says, "Oh my God, I forgot to bring my specs today."
Yeah, that's true. There is, but you.
And after stitching up the patient, he says, "Where did I keep the scissors?"
Yeah, we have to learn to laugh at ourselves as well. So it's important. Yeah, it's important.
Yeah, let's try to see some questions. Jaydev would like to ask a question.
Hi, Ramesh.
Hi, Jaydev.
What I was wanting to ask is this hereditary? This arthritis, is it hereditary?
Is it hereditary, you're asking? Some of them are. Some genetic thing is there, but you don't need to get too worked up about it. So So I think, as I mentioned, try and be active, do your exercises, do your walking, yoga.
Yeah.
Yes, they can be. Some of them are, but don't get too worked up about it. It's
Okay.
something which you shouldn't
That's,
be.
the supplements like omega-3 help in.
Yeah, they say omega-3 helps. I don't know what.
Yeah, well,
to say.
well, if you're happy taking it, go ahead, Jaydev. I'm not going to say don't take it, but there are a lot of drugs in the market and a lot of things which people claim will prevent arthritis. Well, it's very hard to believe that taking drugs will prevent arthritis. But how can one explain that the cartilage damage will be reduced and the synovium will be improved?
Yeah, thank you so much, Jaydev and Lalita.
Thank you.
And you've always been a good enthusiast participating in all the webinars. Thank you. So thanks once again. And Kamala Rangan wants to ask you, Ramesh, what will be the cost of replacement? Kamala
Sure.
Rangan.
Well, normally if you probably about 1.5 L in a decent hospital should be okay. Depends upon whether you want to be in a single room, whether you want computer navigation, whether a straightforward knee replacement is fine. So accordingly, I will say between 1.5 to 2.5 you can stretch it. So again, depends upon which hospital you want to be in. So all those things. But on an average, if you want the cheapest value, probably around 1.5 to 1.75, I would say.
It also depends upon the make of the material of the prosthesis.
Yeah, well, that's what I said. The Modi government has done a good job in reducing the cost of the knee prosthesis to just 55,000. So no matter what the make. So that's they haven't been able to do it for the hips as yet, but for the knees, yes.
Okay. And are these made out of titanium these days?
No. They're made of cobalt chrome alloy.
Yeah, I'm Venkatesh. Dr. Ramesh,
Yes.
just to clarify on the point that you made, this cobalt, does it really have any after effects once the replacement is done? Because it's anyway a foreign body, and does it create some kind of allergic conditions to your adjoining parts, the muscles, the tissues, etc.? What is the problem?
No, that's what I said. Cobalt chrome alloy. It's a mixture of materials, and with the majority being cobalt chrome, it is bioacceptable. It has been approved by the FDA. We've been doing it for more than 40-50 years using cobalt chrome alloy. It's very much thing. It has got no complications, no allergic reactions with cobalt chrome alloy. So you can be rest assured. It is only titanium which used to color the tissues and cause tissue reactions. That's why titanium is used only for fracture fixations, whereas cobalt chrome alloy is used for replacements.
Ilangovan wants to ask you.
Yeah.
He says, my father is 78-year-old. He is able to cycle, not able to walk much.
The cycle on the bicycle.
Yeah, please go ahead. Now you come. You please ask him. Yeah.
Yeah. Good evening, doctor. See, my father, like dad, he complains that during his childhood, when he was sitting on the bicycle, he stuck both his feet. Okay. In fact, made his feet like a little bigger or larger, whatever it is. Okay.
Yeah.
He's been so far okay till 70, 72. Now he is almost 78 years old. Okay.
Yes.
He often complains. His both feet are paining. In fact, a little bit of his legs also paining. So in a day, he sleeps 2 hours and again he wakes up 2 hours. He's not able to walk much, but still he cycles. For a nearby area, he's able to cycle, but he's not able to walk much.
Yes.
So what is the remedy, doctor?
Well, it's very difficult to say whether the problem is coming from the knee or whether there's a problem in the feet.
Okay.
For that, I will need to see the patient. But going by your history, it looks like there seems to be some problem in his feet as well, besides his knee. So I will need to examine him and also look at his X-rays, and then we need to come to a decision. And if we also, is he diabetic?
No, he's not diabetic. No.
Yeah. So we need to examine to see what is the nature of his feet, whether he's got flat feet, whether he's got any other problem with the feet. We need to make sure. And then if his feet are okay and his circulation and his nerve supply to the feet are okay, then it's a problem with his knees. So that's how we need to assess and proceed. So maybe if you contact me I'm back to work from next month, and then
Okay.
you can contact me, and then we can fix an
Yeah,
appointment.
can I have your contact number, doctor? Contact number or like your clinical address so that I can visit you?
Yeah, contact number is 98407
1 minute, doctor. 98407. Yes, go ahead.
55532.
Thank you, doctor. Okay.
Thank you. Thank you.
Thank you, Langavan.
Thank you.
Next, Malini Ramurthy wants to ask you, Ramesh.
Yeah.
Does cobalt not lead to poisoning over a period of time?
No, not really. I think we are going too much into this metal thing. No, it's not. As I said, it's you need to put a prosthesis in which is bioacceptable and which has proven its test of time. We've been using it for all our replacements, so I don't think it's correct to think on those lines. Yeah.
The next one is from Arjun. Good afternoon, doctor. Sometimes I can hear creaking sound from my dad's knee, more like a tack sound when he climbs down the stairs. Is it due to a loss of lubrication in the area, or should it be ignored?
You didn't tell me your dad's age, but anyway, I presume it must be in the 40s or 50s. But but the thing is, clicking noises that you get from the knee joint could be due to various reasons. It could be due to patellofemoral arthritis, which means the kneecap rubbing on the thigh bone. It could be due to your disc, that is your cartilage, that is your meniscus, sometimes getting caught between your thigh bone and your leg bone, that is your femur and tibia. It could be due to some instability in the knee joint. So there are many various reasons why, or it could be even a loose body that is in the knee joint. So we need to assess. Then all the more, he's got a degenerative arthritic joint. So there's no reason, there's not surprised that he's getting these noises. This is basically telling you that your dad's knee is worn out, needs to be replaced if he's fit.
Yeah, the next question comes from Mr. Kannan, headmaster. Sir, my wife, 45, having tennis elbow problem. What kind of treatment possible to reduce the pain?
Okay, is it tennis elbow problem in the dominant hand or non-dominant hand? Well, anyway, whichever hand it is, basically tennis elbow is avulsion of the extensors of the forearm, which means it's a small muscle tear, and it happens because of lifting heavy weights. So I think the best thing to do is to first treat it conservatively, give some ice packs, some hot massages, some rest the elbow basically. Don't lift anything heavy. So probably a quarter bucket of water is what you can lift, not more than that, to tell you in figurative fashion. And to rest the elbow, and maybe after about 3 months to start using the elbow. By the time the muscles will get reattached. If that doesn't work, there is something called as a tennis elbow brace, which you can buy. You can buy a topical analgesics like anything you can get Boveron or whatever. And that's about it. In the very extreme cases, if nothing works, there is surgery in terms of attaching the muscles back to the bone. But that's in rare extreme cases that we need to do that.
Yeah, okay, my name is Nagi Nagalingam, and it's actually early morning for me where I live. It's been a wonderful discussion, Ramesh, and I've known Ramesh for about 50 years.
Yes.
Okay, you're good friends.
He's my schoolmate.
Okay.
But Ramesh, it was a wonderful session, and thank you for sending the invite. More importantly, I have one quick question. So, what is the meniscus? What is meniscus removal? Because my wife had one meniscus done, and now it's looking like the other one, the other knee. So, what's the difference?
No, see, your father must be about 70 years old now.
Oh yeah, usually, you know that.
Yeah, so the meniscus is the basically it's the cushion between the two bones, and that is the thigh bone and the leg bone. So when the meniscus is worn out, and with this at this age, it will be completely worn out. So what happens is when it gets worn out, it just frays and gets stuck between the bones. So do not have surgery to try and sort out the meniscus. It's a bad idea. Not at this age. There is any one surgery that you need to do is a joint replacement. But I'm trying to tell you that trying to do arthroscopic surgery to trim the meniscus or to give a washout of the knee is not going to work at his age of 70 years old.
Thank you.
We feel very happy to get more information, sir, from such an eminent person who has traveled a lot to various countries to study the technology and have come back to our mother nation to service.
Yes.
We have heard saying that we are fully made of bones and flesh. In Tamil, Elumu Sadhiyum Anadana Manida Udambanu. But that shows the importance of bones and an orthopedic surgeon like you. It is really an awareness to us, sir, and mind-blowing speech to get to know more details of the reasons, the procedures and effects of joint replacements.
Yes.
Great, sir. And actually, I feel very proud to say that personally, I've met you in several instances. Either it is for official, personal or medical reasons. You are always very polite and humble.
Yes.
Thank you so much, sir, for being with us here.
Thank you.
And thanks to all for joining us. And we'll be back with new case.
Sure.
Thank you.
Bye.
Thank you.
Bye,
Bye-bye.
Bye.
Thank you. Have a great weekend.
Thank you.
Wonderful session. Thank you.
Thank you. Thank you. Thank you.